I think it's a really hard ask going after Dr. Nihal, one of my teachers. So much work, amazing. So external pancreatic fistulas, I'll start off with basically just an introduction, just to say that, as we know, it's just an abnormal passage that develops between two surfaces. Here we're talking about the body surface, the skin, and the pancreas. It's a communication between the pancreatic ductal system. It could be internal or external, but here my focus is primarily external. And it could be iatrogenic, where it could be following a surgical procedure or an intervention, but sometimes it can happen in cancer otherwise as well. Like I mentioned, internal or external, and pancreatic disruption, ductal disruption, partial or complete, really is the key here. So we'll start with the case, and I'll try to focus on that. So this is a gentleman who came to us actually later on in his care, but he was unwell with biliary pancreatitis. He developed an intra-abdominal collection, which in the center he was treated. Surgical options were available and endoscopy wasn't. That was offered to him, fair enough. They removed the gallbladder at the same time. Post-operatively, he developed fever, and since he was found to have a collection, he had a percutaneous drain placed. 3 months later, the drain was removed, but there was a collection. The collection subsequently came down, but he persisted to have a fistula. I mean, he persisted to have output. So this is the situation in which he came to us. No collection, but there was the persistent fistula. So going back, so we need to know that there's a cutaneous fistula because there's disruption of the duct. The pancreatic juice is leaking out, and it's seeking the path of least resistance. Sometimes that could be to the skin because of something we've done, or naturally. It's defined as either high output or low output. The cutoff that's used is 200 ml in a 24-hour period. And it may not be so relevant to the gastroenterologist, but I think for our surgeons, there may be some here, I'm not sure. The timing is also, it could be early versus late. What we probably see is late, while our surgical colleagues may see it a little early on. This is some interesting information. It's pretty common sense, really, but what makes you more likely to develop a fistula? So this is one of these, is a Ukrainian study. It kind of tells you that if you have superficial damage to the pancreas without the pancreatic duct being damaged, you're not really going to get too much trouble. However, if you have a deep injury to the pancreas involving the pancreatic duct in a short segment, that's really where, and that's what's likely to lead to disruption of the duct and cause your pancreatic fistula possibilities or risks of. The other study, it pertains to the fact that if you were aggressively trying to dilate a percutaneous drain, upsize, and if you needed to make it large enough such that you needed to do a VATS procedure, that's likely more, you're putting yourself more at risk, or putting the patient more at risk to develop a fistula. Common sense, possibly it all fits in. So what do we do? So obviously the key really is to quantify, because that will guide you on how you need to make the treatment. You need to assess and make sure that this is pancreatic. We'll do that by checking the amylase level on the fluid. And a cross-sectional imaging is really important for you to kind of outline the anatomy to make a plan. There is a classification system. I'm not sure it's very relevant to us, but it's important and can be used to kind of guide, and maybe if we publish or subsequently to kind of say how severe the fistula was. So if it used to be called grade A, but this is just biochemical leak, basically not clinically relevant, just settles on its own. Grade B is when you need intervention. It's persistent for more than 3 weeks, and it requires you to change your management in some form. It's endoscopy. You could get radiologists involved if in some situations they've done that. And grade C is basically when you need to have surgery. So I'll outline it. It's not exactly like this, but I mean, this is possibly the path that most of us will follow. So we'd probably say a conservative approach. If that's not working, we may escalate it to secretion therapy. I'll talk about the evidence for each of these subsequently. And then intervention in the form of an ERCP, sphincterotomy, bridging, and moving upwards, we may have an EUS involved with trying to connect the tract to the stomach. And alternative options are also there. Finally, a surgical option may also be required. I won't be touching too much into that. So let's start with the conservative approach. And so this is a study from Dr. Rana's group. It's from PGI. It's a small study, 33 patients, but it kind of does tell us, and it fits in with probably what a lot of us do follow. So if you don't have a large output fistula, so all of these patients had an output of more than 50 ml, so it was persistent, and none of them had any secretory therapy done or any other intervention done. And the mean closure time was about 3 months. So it does say that conservative management is acceptable, and we don't need to jump the gun and try to do something immediately in every situation. So going on, about somatostatin analogs, if you say you wanted to add this in, what is the data on that? I think there was a lot of support from the surgical side, where initially to prevent post-op leaks, there was some moderate benefit that had been shown in earlier studies, and as well as some meta-analysis that had said that there could be some benefit in preventing post-op leaks. But a subsequent meta-analysis, which is more recent, has stated, this is I think 2025, has stated that really routine use of somatostatin analogs is not really supported. And it seems much larger, over 6,000 patients. So I think at this point in time, it doesn't seem to have a role in prevention. What about from our point of view, from the gastroenterologist point of view, should we use it? And I know a lot of us have used it. I'm also a culprit. I've also used it, maybe once or twice. But does it have a role? There's not much information. Very, very small amount of patients. If you look at this, it's an old meta-analysis, but it says it's just 102 patients who were pancreatic. The rest of them were all other gastrointestinal fistulas. And it's really, the data is really patchy, inconsistent reporting. But we can say that there's no solid evidence to support its use. So I'm going to say at this point, we have evidence that you don't need it and it closes. And I don't think it probably needs to be there routinely. So what about ERCP and stenting? Really nice information. So if you have a disruption, there is a meta-analysis that says that endoscopic transpapillary drainage is adequate, works in up to 80% of the time, a large meta-analysis. This is for disruption. And there's a series from the US of 107 patients with a fistula. And it says that they successfully treated these patients in 75% of the time. Obviously, success is greater if it's a non-acute pancreatitis setting and if the duct disruption is not complete. Makes sense. This is a nice study, 2022 from Sridhar in Bombay. So this is Indian data. And it says pancreatic patients with fistulas. ERCPs were successful, and they were able to bridge the leak in 2/3 of the patient or more. So 70% bridged. Success, 90%. So partial disruption, stent, 90% success, over 90% success. In 1/3, if you're not able to bridge, stent, you still succeed 75% of the time. So definitely there appears to be a role of ERCP transpapillary stenting if, in this situation. But what everybody is interested in, I won't talk about duct disruption because I think Dr. Amol really gave us an extensive talk on that. And the catch really is, if there's a fluid collection and a leak, you just drain it transpapillary. And I'm sure all of us will be doing that pretty straightforward. The problem comes, Guru, this picture is from one of your reviews. I just stole it. Yeah, okay, and but I've credited it. So you can see that if there is just a tract, connecting the tract to the stomach is sometimes a challenge. It's possible without any assistance that you can put a needle in, put a wire out, and get into the tract, but sometimes it is difficult. To do. So this is a relatively recent review of the rendezvous that were done to kind of internalize the tract of external fistulas. There's two ways to do it. You can go from inside out, or you can go from outside in. Outside in is with probably the radiologist will do it. There are some theoretical risks of damaging blood vessels and causing some harm. We would, if as gastroenterologists, what we would do is probably go from inside out using the endoscopic ultrasound. But this is just to say that it's technically feasible, and if you were able to bridge it, the closure of the fistula is consistent and quite good. And there is, however, as mentioned earlier, there is a risk of new onset diabetes that can occur. I don't think there's anything we can do about it from this procedure. I think that's the nature of the disease, so I don't think closing the fistula or not is going to make a difference there. So when the tract is not, if it's just the tract and no collection, what are the methods that we can use? So this technique, what we used is, it's accepted for publication. It's basically, we used a balloon. We can go to the next slide. So we used a balloon to, we took out the drain, we placed a balloon into the tract, and we inflated the balloon. So it's an easy target on an endoscopic ultrasound, and you just puncture and damage the balloon, and the wire gets into the tract quite easily. Very simple, not very expensive. You lose just a balloon, no problem. While this is one of Vikas's, I won't play this as well. It's too long. It's 5 minutes, and I'm not able to fast forward it. Oh, can I? No. So, that's fine. So, what Vikas did was he took out the tract, and then he used another scope, and using the scope he he pushed water in, dilated the tract, and then under vision passed a wire and brought it out through the tract. Both these times, what we're doing is we're internalizing the fistula. So you're giving a pathway so that the fluid tracks into the GI system and not outwards. So Vikas said you could use a pediatric scope, or you could use a spyglass as well. So these are two options. I couldn't find a video for this. Another thing that's been used is you can pass a snare into the tract. You can open the snare out and you target the snare and try to see whether you can bring the wire out. So basically, you're just trying to see where the tract is for you to pass the wire through it. Glue injection also has been tried, very few cases. I'm not very sure of its success. I know Itish has closed one fistula with some glue, but I have really no experience. So surgery, I won't talk too much because it's probably way out of my area. But surgery has some limited role. So if you have a mature tract and good upstream pancreas, a diversion surgery is possible. It does reduce the risk of new onset diabetes as opposed to something that is more aggressive. If required subsequently, then distal pancreatectomy would be preferable. So obviously this is only possible in distal fistulas. Complete pancreatectomy really, unless you have no other way, I think it should be avoided. So that's a basic approach. I would say thank you. So